Opioid overdoses are driven by more than just addiction. Stigma, discrimination, and lack of access to the right care set the stage for rising statistics. But those affected aren't numbers on a page. They are loved ones with diverse life stories who leave many chapters unwritten. You can help rewrite their stories. Studies have shown that without opioid agonist treatment, naloxone dissemination, and access to supervised consumption sites, death rates may be much higher. Randomized controlled trials have shown that initiating buprenorphine naloxone in the emergency department dramatically increases patient transition to and retention in community treatment. Buprenorphine naloxone, commonly known as Suboxone, saves lives and is easy to initiate. First, assess if your patient has an opioid use disorder. This is confirmed using the criteria in the DSM-5. A simple way to check is referred to as the 4 C's. Do they struggle with cravings? Do they have a loss of control over the amount or frequency they use? Do they have compulsions to use? Or do they use despite consequences? Consult the 24/7 Addiction Medicine Clinical Support Line if you're unsure. If the patient isn't ready for treatment, connect them to local overdose prevention and substance use services. If they are ready to try buprenorphine naloxone, review the inclusion and exclusion criteria found on the Interior Health Regional Adult Buprenorphine Naloxone Pre-Printed Orders, PPO. Inclusion criteria must include the patient is older than 17, gives informed consent, and meets the criteria for opioid use disorder based on the DSM-5. Exclusions include allergies to buprenorphine or naloxone, severe liver dysfunction, already stabilized on an OAT program, acute alcohol intoxication, or decreased levels of consciousness. Pregnancy is a relative exclusion. Contact the Provincial Race Perinatal Addictions Line for advice. Assess the patient with the Clinical Opiate Withdrawal Scale. A COW score of more than 12 and sufficient time since the last opioid use is necessary to begin induction. Follow the time criteria found on the PPO. Start with a 2 mg test dose. Observe for 30 to 60 minutes, and if there are no signs of precipitated withdrawal, continue with 2 mg every 1 to 3 hours until symptoms improve, or for a maximum of 12 mg in the first 24 hours. If the patient's COWS is less than 12, the patient may be eligible for a home induction. This would provide the patient a 72-hour Suboxone to-go pack, allowing them to start their Suboxone at home. It includes enough medication to support the patient until they receive care in the community. Ensure the patient understands the home induction process by reviewing the Interior Health Suboxone Take-Home Patient Information found on the Suboxone in the ED Toolkit on InsideNet. Once the patient feels better or is going home to a home induction, provide them their 72-hour to-go pack, education materials, and harm reduction supplies. Scan both the PPO and the dispensing referral form to both a pharmacy and Urgent OAT at interiorhealth.ca. The Urgent OAT program will ensure they are followed up in the community within 72 hours or less. If you choose compassion, you can help stop stigma and save lives.